Hi everyone, we're going to talk about hematological disorders. Several of the first slides are more self-explanatory and we'll go over them briefly, but I'm not just going to read them to you. I don't want to waste your time. First off, we know that the hematological system is a large fluid organ and it's essential for carrying nutrients throughout the body. It is made up of many cellular components. The plasma is the transport of the cells. We have red cells called erythrocytes. We have white cells called leukocytes, and there are several subcategories of the white cells. And then we have platelets, which are called thrombocytes. During the second semester, blood is primarily formed in the liver, spleen, and the lymph nodes. And in the last half of gestation, homeopoiesis, which is that formation of the blood, shifts from those organs into the bone marrow. The bone marrow is the primary production center of all cells of the body. The kidneys help in that a little bit. The first thing we're going to talk about are the erythrocytes, or the red cells, and this production of these cells is determined by erythropoietin, which is primarily taken care of in the bone marrow, but as I said previously, is produced a little bit in the kidneys, and that does help with stimulation of the red cell production. To have this red cell production, the body needs certain nutrients such as iron, B12, folic acid, and amino acids. All of the cells in the bone marrow are undifferentiated when they're first developed, and based on what the needs of the body is at the time is what they become. So as an RBC becomes differentiated, the nucleus is replaced by hemoglobin. These cells have a biconcave disc shape. The reticulocytes, which are the youngest RBCs that are out there, tell a lot about the production of the bone marrow, and a reticulocyte count is a reflection of how much erythropoiesis is going on in the rate of production of these cells. And most red cells live anywhere from 90 to 120 days. So if you're having, if your patient is having issues with any forms of anemias, it's going to take that impact the red blood cells. It's going to take a little bit of time before you see impact from them, unless it's an acute blood loss. And then also it's going to take anywhere from 90 to 120 days to see improvement of those cells for whatever intervention you are using for the issue. As we know, hemoglobin is the oxygen-carrying molecule of the RBCs. We talked previously about the production requires circulating iron to help make it. Good nutrition is essential for this cell's reproduction. As you see, iron is needed in that production, and if the diet of the patient is lacking in certain elements, then there's going to be a reflection in the blood cells in the body. There are several different types of hemoglobin that are found in the embryonic state, in the fetal state, and the adult state. And so hemoglobin F is a fetal hemoglobin, hemoglobin A an adult hemoglobin, hemoglobin A2 is a mutation in beta thalassemia, and hemoglobin S is a sickle hemoglobin. We're not going to go into much detail on these structural variations, and if you're looking for more on that, it's in the first page or two of your chapter. So some of the normal values, while hemoglobin is fairly consistent in adults, we know that it increases with increased gestational age. We also know that there is a drop in the hemoglobin level in the 2 to 4 month range in term infants, and about 6 weeks in premature infants. Hemoglobin levels for a newborn range anywhere from 14 to 20, but may be a point or two lower in a low birth weight baby. As we said, we know that these levels drop in babies anywhere from between 2 to 4 months, and that is based on the life cycle of the red cell. And then also there is an increase in blood volume, which causes some hyperdilution as well. As with adults, red blood cell issues, the anemias are categorized on the basis of the RBC size and the appearance of the cells. So you can have macrocytosis, which are large puffy cells, microcytosis, which are smaller cells, normocytic, which are normal appearing. As with adults, there's the antigenic properties of the RBCs, and the most common are AB and RH, and a person either inherits an A or a B, or both antigens, which is an AB, or neither antigen, which is an O. In the U.S., the majority of Caucasians and African Americans are Rh positive, and this typically does not pose any issues unless we are getting into discussions on blood transfusions, or there's concern about any maternal fetal incompatibilities. So let's move on to the leukocytes. We know that those are the white cells that protect the body from invasion by foreign organisms and distribute antibodies. As with adults, we know that white cells that are too low raise your risk for infection, and this can be fatal. And we know that white cells that are too high indicate massive infection or leukemia. We have two different subcategories of leukocytes. We have granulocytes and agranulocytes, and we have, under the granulocytes, we have neutrophils, eosinophils, and basophils, and under agranulocytes, we have lymphocytes and monocytes. There's a great table in your chapter, table 27-3, that gives an overview on the leukocytes, and then also gives you a diagram on kind of what they look like. So let's talk about a little bit about neutrophils, basophils, and eosinophils. Neutrophils are, their major purpose is for phagocytosis. They go in, they find what they want to destroy, whether it's bacteria, and sorry for that, I had a phone call that I needed to take. So we know that the major function of neutrophils is for phagocytosis, to go in and ingest bacteria, and they are the primary white cell that is used to fight bacterial infections. A term that you may hear is a shift to the left, and when you see an increased number in the circulating immature neutrocells, which includes bands, etc., that are associated with infection, you might see that or hear the term shift to the left. Another white cell that is there is basophils, and they're very similar to mast cells, and they're there with the release of heparin and histamine in allergic reactions. They kick in when there's a hypersensitivity reaction going on. If you see elevated basophils, it may be associated with kidney disease, some carcinomas, and medications such as estrogen or antithyroid meds. The last category of granular leukocytes are your eosinophils, and those are your immediate release histamines, and they also work on destroying parasites. So if you see a CBC diff that has elevated eosinophils on it, the first thing that you might want to check out are they having allergy issues. The next category of cells that we have are your lymphocytes, and we know that they make up about 25 to 35% of the WBCs, and although they don't go in and eat things up, they protect the body against specific antigens. These cells originate in the bone marrow, but then divide off into the lymph tissues, such as the spleen, the liver, the thymus, lymph nodes, and the intestines. The T cells, those are assist with cell-mediated responses when cytotoxic agents and macrophages are synthesized, and the B cells are the precursors of the humoral immune response, where the cells are made into plasma cells and then released as immunoglobulins or antibodies in the bloodstream. And they're a very important part of our defense against viruses. Another agranulocyte is our monocytes, and those are relatively immature cells. that circulate for about 8 hours before they migrate into tissues where they assume the role of macrophages. Once they've developed into macrophages, they are primarily found in the liver, spleen, and the lymph nodes in the GI tract. They are the first line of defense against microbial invasions, and their primary function is phagocytosis of bacteria and cellular debris. If you're noticing an elevation in the monocytes, you need to be watchful for collagen vascular disease, Hodgkin's lymphoma, non-Hodgkin lymphoma, and chronic infections such as tuberculosis and syphilis. The next cell we're going to talk about is platelets and the coagulation factors that they offer. We know that they are smaller in size than the red blood cells, but they're essential for hemostasis, and clot formation. We also know that platelets are fragments of megakaryocytes, which are the precursor cells that form in the bone marrow. A normal platelet range is anywhere from 150,000 to 450,000. We know that when blood vessels can be injured, or if there's a presence of an intrinsic damage to the blood, that platelets will adhere to the inner surface of the vessel and form a plug. And then as platelets break down, there's a series of 13 clotting factors and enzymes that are released that bring about the clotting process to work to make that clot. And the specific clotting factors can be found on page 27-5, table 27-5. There are several factors that go into making the clot and the cascading process, and those include prothrombin, thrombin, fibrinogen, and fibrin. So let's talk about a little bit about some different disorders of red function, white function, and platelet function. So some different disorders of the erythrocyte. When you're going to assess for these, it's important to get a good history. You want to assess for any genetic history, ethnicity, and race, especially when it comes to sickle cell. You want to assess the family history, the child's medical history, were there any issues with prematurity, any environmental exposures, chronic illnesses that you are not aware of, persistent pale skin, jaundice, unusual blood loss, petechiae or easy bruising, do a nutritional screening, and what did their newborn screening show. On physical exam, you want to, of course, assess vital signs, compare growth charts, see patterns that you have noted. Notice any pallor or any jaundice. Notice for a petechiae, retinal hemorrhage, any excessive bruising or any bleeding from the mucosal areas, any lymphadenopathy, any issues with the frontal bossing joint or extremity pain, any heart murmurs, any enlargement of the liver or spleen, and note for any congenital abnormalities. Be sure and review in the book under pathophysiology of the red cell some other history questions or areas that you might want to delve into. We won't go into that now. One thing that you can see is called pancytopenia, and it's a decrease in all three formed elements of the blood: the red cells, the white cells, and the platelets. And you may see this not as the result of a single disease, but the result from a combination of disease processes. And so pancytopenia can be caused by one of three processes, and that could be production failure, where the bone marrow is not producing as it should, such as aplastic anemia, sequestration, where this is where the spleen is overproductive, overactive, and it removes blood cells too early and too quickly from the body. And then increased peripheral destruction of mature cells, and this can be associated with infections and some medication use. So if you're concerned about and seeing pancytopenia in your patient, then that is a referral to a pediatric hematologist. Okay, let's talk a little bit about some erythrocyte disorders. First being anemia. It is a reduction in the circulating RBCs, whether that is from decreased production, abnormalities in the RBCs, whether they, for whatever reason, are having a shortened life cycle, or we're having increased destruction of them. There are some types that are of anemias that are seen in specific races and in specific geographic populations. And these may be your sickle cell anemias or your GCPD deficiencies that may be seen in African patients with sickle cell, or those of Mediterranean descent for your G6PD. Good nutrition is essential for the production of red cells, and so if you're seeing a child that has some nutritional deficiencies, you should expect possibly some problems with their blood cells. And also, if you've had a child that's had toxic ingestion of some chemical, this can also cause anemia. We know that the importance of having the blood circulating through our bodies and all that it carries with it, primarily oxygen. So when we see anemia, we do see stressors to the cardiovascular system and to the respiratory system. Most kids that are anemic are usually asymptomatic. This has been a gradual process that has occurred, and their bodies have learned to compensate. There's an excellent table, 27-6, which talks about acute anemia in childhood and adolescence, that gives some more detail of how anemias are classified, whether they're microcytic for iron deficiency, macrocytic for like B12 deficiency, normocytic, whether they're hemolytic, or if it's related to blood loss. So I encourage you to review that table 27-6. So 90% of anemias in children are iron deficient, lead-related infection, or hemoglobinopathy. It is the most common cause of anemia worldwide. We know with iron deficiency and lead issues that there's a reduction in hemoglobin available to transport oxygen throughout the body. Anemias can also be caused from inadequate red cell production, which could be acquired or constitutional. Table 27-7 gives us a little bit more information on red blood cell disorders that are associated with anemia. It talks in regards to what history might be seen, physical findings, lab diagnoses of more common RBC anemias. So you'll find more information on iron deficiency, alpha and beta thalassemia traits, hereditary spherocytosis, chronic inflammation, and lead intoxication. Anemias can also be caused by failure of the erythrocyte in the bone marrow to produce, and that is termed as a hypoproliferative anemia. As we talked about, iron deficiency is the most common. Your thalassemias are genetic. The workup that you'll do for anemias include a CBC. You want to screen and check for your hemoglobin and hematocrit. It's important also to check for RBC indices and morphology, such as your MCV, which is your mean corpuscular volume, which is going to tell you size, and the other MCHC, etc., that are found on a CBC. It's important also to get a reticulocyte count, as it is an indicator of how well the bone marrow is producing, and then also a peripheral smear will give the pathologist in your lab an opportunity to look at the cells under the microscope. Follow-up labs would include a CBC, an iron, a TIBC, and a ferritin. So some more about iron deficiency. It's considered a microcytic anemia. The cells are small. Your MCV will be low. There can be a defect in the hemoglobin or the globin synthesis. We know that there can be decreased iron delivery to the marrow, and this can be caused by chronic inflammation or iron deficiency. And then we also know that there can be a defect in the globin chain synthesis, and that's seen with thalassemias. So, the most common nutritional disorder, it's noted to be more prevalent in Black and Hispanic children, also noted in childhood obesity, prematurity, and low birth weight. There is a correlation with rapid growth um, after a low iron diet. Okay, I'm rereading that, and that is cannot be right. So there is a correlation, I think it should say, between slow growth and a low iron diet. We know that with malabsorption of the iron, you can see that with Crohn's disease, giardiosis, celiac disease, and a resection of the small intestine. You'll do some universal screenings for hemoglobin at 12 months and along with assessment for risk factors, and you'll do that more frequently if you're concerned that your child, the patient, is at risk. With this age group, most testings are completed via finger sticks. It's important to use proper technique when doing this, as excessive squeezing of the finger can produce inaccurate results, such as a low hematocrit. And then a venous sampling, so a peripheral stick, is the most reliable indicator. If you have a child and they are showing that the hemoglobin is low and there's concerns for iron deficiency and the dietary patterns are consistent and a microcytic anemia is seen, it is appropriate to begin a trial of iron for 4 to 6 weeks without any further diagnostic testing, and then follow up the child's hemoglobin and the retic count to see if you are seeing improvement. That follow up should be, as I said, in about 4 to 6 weeks. And then, if improvement is not seen, then a referral to pediatric hematology is warranted. So, some of the effects that iron deficiency can have on your patient is possible cognitive defects and also some increased absorption of lead. There is a high comorbidity between iron deficiency anemia and lead poisoning, especially with lead levels greater than 10, because the lead molecules block iron from binding, and this inhibits the transfer of enzymes. Some clinical findings that you may see in your patients with iron deficiency may be irritability, restlessness, pica, eating things that are non nutritional. You may notice anorexia with a hemoglobin less than 8, and there may be developmental delays or social emotional disturbances. On physical exam, you may note that there's pallor to the skin. You may notice that their conjunctiva is pale or the mucous membranes are pale in the mouth. You may see tachycardia, you may hear a murmur, or you may see signs and symptoms of congestive heart failure. And in severe anemia, your stool guaiac testing is important to rule out that there's not a loss of blood in the stool. Let's talk a little bit more about what the labs will show. So we're assessing, of course, for the hemoglobin and hematocrit, and your first thought may be iron deficiency if you see a low hemoglobin in the 8 to 11 range. If you see a patient that has low iron intake and no other causes, it might be considered a mild to moderate case for a hemoglobin of 7 to 10. Less than 7 is to consider a hematology consult, the recommendations say, and less than 4 is to consult with a hematologist. The RDW, which is the red cell distribution width, is the earliest marker of iron deficiency. You'll also notice that your serum ferritin is low. And then, as we talked about, we had the comorbidity with lead poisoning for greater than 10 in lead testing. So on this screen, this is what a typical profile might look like for iron deficiency. You're going to notice that your cells are microcytic, so your MZV is going to be low. They're going to be hypochromic RBCs, lower in color. You can have a high RDW. Your ferritin can be low, and your TIBC can be high. And the Menser index, it can be greater than 13. Some differential diagnoses that you would consider are other microcytic homochromic anemias, such as lead poisoning, thalassemia minor, chronic diseases, and hereditary sideroblastic anemia. If you don't receive a response to iron therapy in 1 month, then that would require a workup. Further labs such as CBC with a diff, platelet count, RBC indices, and then a retic count, and of course assess for occult blood loss. Management of iron deficiencies include iron supplementation with ferrous sulfate, and your dosing of that would be 4 to 6 milligrams per kilogram per day of elemental iron divided into 2 to 3 doses, or 3 milligrams per kilogram per day divided into 1 to 2 doses. If there are mild symptoms of IDA. Important for kids to reassess hemoglobin and hematocrit in about 4 weeks, and to see what the response is to the iron and see if you're getting to a therapeutic level. You should be able to see improvement in the reticulocyte count after about 4 days if you were checking that, and it's important to continue iron supplements for 2 to 3 months to get levels back to therapeutic ranges. And then it's equally necessary to continue on for several months after that so the iron stores can be resolved, and then recheck these labs all again in 6 months after iron supplementation has been stopped to determine if the resolution has occurred and you have enough iron for daily use, and then ferritin in to control the stores. Okay, so if you have a little one who's being exclusively breastfed and they're needing iron, you may be giving 1 milligram per kilogram per day at 4 months. We know that it's important to continue this supplemental iron until the child is taking foods that contain iron in satisfactory quantities to maintain their iron levels. Babies that are receiving formula are covered with iron, as those are fortified, and we know that whole milk should be avoided until the child is 12 months old. Compliance can be an issue, and it's recommended that liquid supplementation is given until 36 months, and then after that there's chewable vitamins that older children can take. It's important though that the parent talk with the provider about the specific formulation to make sure that that's meeting the needs of the child. Patient education and family education is important for these patients. We want to increase iron-rich foods, as we talked about, iron supplementation for exclusively breastfed babies at 4 months. Avoid cow's milk. Goat's milk does not have adequate iron and folic acid to help with growth, and avoid giving iron with milk, as the vitamin C enhances absorption, and that is needed to help absorb the iron into the bloodstream. You may need to educate your parents that their stools will be black, and then it's important to keep medications out of the way of children's hands. Okay, we're at the end of this video. It went much longer than I anticipated, but I kept thinking iron deficiency would end. So we're going to end this and then start back up with thalassemias. Thanks.